Welcome everyone to today's Eczema Awareness Month Q&A webinar. My name is Cheryl Talent and I'm the President of the Eczema Association of Australasia and New Zealand, Inc., also known as the EAA and EANZ. Thank you so much for taking the time to join us today for our Eczema Awareness Month Q&A webinar. We really hope that you can learn a bit more about you or your loved one's eczema to provide them with some tips, resources or new insights on eczema. To begin, I'd like to introduce you to our panellists for the day. We've got with us today Specialist Dermatologist Dr. Kate DeAmbrosis from Mater Public Hospital and Valley Plastic Surgery, and Professor Rod Sinclair from Sinclair Dermatology, who will be able to provide you with some great insights into eczema and what is happening with eczema in Australia today. There's some exciting new changes coming. In today's session, we will learn more about the EAA and EANZ and how we can help, and Dr. DeAmbrosis's and Professor Sinclair's experience before we head into the Q&A session. If you have any questions while Dr. DeAmbrosis, Professor Sinclair or myself are presenting, please make sure to write your questions in the chat on your control panel. We will then be responding to these questions in our Q&A time. Please note, we do only have a limited amount of time for questions, so if we run out of time and are unable to answer your questions, please send them through to either help@eczema.org.au or give us a call on 1300 300 182. This session will be recorded, so we will be sharing the audio visuals from the webinar onto our website and socials if you need to refer back to this once the webinar's finished. We hope you learn a lot today from today's session, and we welcome any feedback in our post-webinar survey, which you will receive once the session has concluded. To start with, I'll provide a little bit of background on the EAA and EANZ and the importance of understanding the condition for yourself or your loved ones. So, understanding your eczema. Managing eczema to prevent flares is a constant battle for sufferers and can have a major impact on their daily life. We know that eczema is misunderstood and can exact a significant physical and emotional toll on sufferers and their carers' quality of life. Treatment information can be conflicting and very variable. One person will tell you one thing, another another. The Eczema Association of Australasia, the EAA, and the Eczema Association of New Zealand, the EANZ, are non-profit support organisations. Just shut myself down. Are we right? Sorry guys, bit of a glitch there. The EAA and EANZ provide support and education for eczema sufferers and carers, along with the wider community in all aspects of eczema and its impact. We are a shoulder to lean on. We've just recently, for Eczema Awareness Month 2020, launched a report outlining data from surveys and findings that we have been collecting for the past 25 years. So how does eczema impact Australians? And we do know that New Zealanders, the numbers are slightly lower but very similar. So 66% of eczema sufferers were diagnosed before 2, which would, fall in line with what we sort of already knew. 72% of participants found that weather was a major trigger. So we know weather can be a big problem. So in Australia, that's why we always have Eczema Awareness Month with the onset of winter and the drier, colder weather. That's when most people will experience a major or minor flare. 6% said their eczema was controllable. So that leaves a lot of people who are having a lot of trouble managing their eczema. 52% said it was chronic. So that means that they find it very difficult to get help and to get some sort of management. And we know that people spend a lot of money when they have eczema. It's one of the most expensive diseases you can have, even opposed to things that are life-threatening like diabetes, where you get a lot more government assistance. So what help is available? Dermatologists and chemists are two of the most commonly seen professionals that are valued as the most helpful for eczema sufferers. So we need more answers to the eczema problem. Research, especially research going on overseas, but also in Australia, is starting to provide some better treatments for some better outcomes. We also find that education promotes better management for sufferers. There's still a lot of people who suffer from steroid phobia. That's why education is an ongoing exercise that needs to be carried out. So every year we run an Eczema Awareness Month and an Eczema Awareness Day. The Eczema Awareness Month is in May, and we try to reach as many people as we can to let them know that help's available. And we have an Eczema Awareness Day in September because spring, again, is a time of the year when a lot of people will experience a flare. So the EAA and EANZ are a platform, and we like to engage our members in research. So we often will feature on our Facebook pages, or we'll send out an EDM to our members about latest research projects. And it's a wonderful way to get people who, you know, really is something they are interested in and they're very happy to engage in. So it's a great way to get a targeted audience to participate in targeted research. The Eczema Association also is the only organisation that produces a magazine for its members, which they all love reading. We also have a lot of educational literature. We've just brought out for Eczema Awareness Month a new eczema care plan, which is very simple. And we just try to keep people in touch with what's the latest and greatest. Our social media platforms such as Facebook, Twitter, Instagram offer lots of information and helpful tips, and we also feature stories from sufferers which, you know, can be quite helpful. You often learn lots of things from what they've done in the past. Usually, this year's a bit of an exception, we attend lots and lots of events. As you can see, that was our calendar of events for this year, but it's sort of been a bit changed. That's why we're running this webinar. So we're still trying to reach out to people and spread that message about education. We work with a lot of health professionals, other organisations and companies who are interested in finding better outcomes. That might be different products that you use, better understanding of treatments. So it's our role to sort of engage with all these different types of people and find out what's best for you, our members, and members of the public. So let's all work together for some better outcomes. Thank you very much. Now I'd like to now introduce Kate DeAmbrosis. She's going to give us a little overview. So thank you very much for listening, and let's listen with interest to Kate. Thank you.
Thanks so much, Cheryl, and thanks to EAA. They're doing a fabulous job. I'm amazed 25 years worth of survey data is a great effort. And not many skin diseases have a support group like EAA, and I know my patients definitely benefit enormously from the work you do. So thank you very much for all that work you put in. 6% of patients feeling their disease is uncontrolled is quite alarming for us to hear as health professionals. So I think we can do a lot better there, and things like this are instrumental to making that happen. I work in 2 locations. I work at the Mater Public Hospital at South Brisbane in a general dermatology and also in an adolescent dermatology clinic. And I also work privately in a practice called Valley Plastic Surgery with these lovely doctors on the next slide. And so I thought today I would mainly focus on what is eczema, how it comes about, and have a look briefly at how it can look quite different in different age groups, but also in the same patient in different stages of life, before looking very briefly at management. So eczema, the word itself, it's quite an unusual word, and it's derived from a Greek word meaning to boil over. And I think if anyone has suffered eczema, that would ring quite true, that the skin does feel like it's erupting, these patches that once it gets untreated and out of control. And I find with my patients particularly, once that happens, it can even have an overflow into mental health and the feeling that you're boiling over mentally too. When people are assessing for eczema, you might see doctors talking about an atopic diathesis or an atopic triad, and that refers to eczema coexisting with other diseases like asthma and hay fever. And that's because they are genetically linked. So often when I'm taking a history to assess a patient and how their eczema may be developing, I do often ask if there's any close relatives with any of these three diseases. So next slide. Eczema can look quite different, both in different skin types and in different phases of life. So it's often termed the itch that rashes, as opposed to other diseases where the rash can present first and then become itchy. This disease can look quite bland and like nothing much at all until the itch sets in, and that itch is scratched and develops the rash. And that sets up a vicious cycle in the skin, and quite a degree of inflammation then presents, as you can see on this slide, in a more typical fashion. So dry skin is itchy, and that is a very debilitating component of eczema. And when we're assessing patients with eczema, we often ask them to give a severity score of how much impact this itch is giving on their day-to-day life. And that's a really good marker. If we can control the itch, then often we can get control of the disease. Sleep deprivation is the #1 impact that itch has on lifestyle. So I'll regularly ask my patients to rank their sleep score out of 10, and that can give me some feedback onto how their treatments are going. Eczema can take this form, secondarily infected eczema, once there's secondary bacterial or viral disease complicating that impaired skin barrier. And the next slide shows what chronic untreated eczema looks like. So the skin can thicken in response to the chronic inflammatory process that's happening in those deeper layers to look like this. So what causes eczema is quite a complex interplay of both a genetic predisposition combined with environmental exposures. And one of the things I particularly struggle with when I'm giving a diagnosis of eczema to parents of young children is that it's really a complicated thing to describe that this child has a chronic disease, and then I can't give them one cause that is the only cause for this. It's such a complex interplay of these two factors, and it's impossible to separate them. But the biggest background cause of eczema is the genetic predisposition. And often I like to use the analogy of a brick wall in describing how this happens. So if you can imagine the bricks and the mortar that go into making up a nice, neat, evenly distributed brick wall, the filaggrin protein is one key to our skin structure that acts as the mortar. So in eczema, we find that this filaggrin protein on the first chromosome is quite affected to varying degrees, so that mortar is not working as it should. So it's not holding the bricks together in the way that ordinarily it would. So instead of having the nice even structure of a brick wall, you have instead in your skin a dilapidated, quite unstable brick wall structure. So that is the underlying cause of why things trigger flare-ups, why the skin breaks down, why we can run into problems. We go to the next slide. So this is a list of not universal, but quite common triggers that I see flaring eczema, and it can vary depending on the age group and what that child or adult is exposed to particularly. But usually patients with eczema, with that filaggrin deficiency, are a bit more susceptible than people who don't have the filaggrin deficiency to having breakouts with these exposures. So winter weather, as Cheryl alluded to that in her survey, that was noted as a particularly common trigger. Frequent washing, particularly with excessively warm water. Soap has an ingredient called sodium lauryl sulfate, which tends to strip that brick wall barrier down and make the skin more susceptible. Antiseptics, low humidity, high temperatures, but also changes in temperatures, chlorine and sand. And so they're the ones that we particularly note can trigger off eczema flares. Now, eczema, as I mentioned, can look different in the same person, but across different phases of their life. And that's because at different phases, skin is more susceptible to different things. So as a young baby who's immobile, they're generally in more of an oral phase of their life. They're putting hands near their mouth, they're drooling, objects are being mouthed commonly. So there's a lot of salivary irritant that generally presents as facial eczema. As that child grows up, and particularly as they become mobile, then it's the surfaces that are in constant contact with the ground and with other objects that tend to develop the eczema. So wrists and knees and lower legs. As the child is upright and walking, then we tend to see the eczema become more evident in flexural skin, so cubital fossa around their elbows and behind their knees. And that can be because sweat irritates that skin, and it's a common area for rubbing and friction of clothing sites as well. With adults, and I think it's, we'll come back to that later. So these photos, next slide. Yeah, thanks, Hannah. Next slide. These photos display what quite common child or baby infantile eczema looks like. So it tends to be quite erythematous, circumscribed areas on the cheeks. Whereas if we go to the next slide, preschool eczema tends to be a lot messier, and that's because their exposures are quite different now. They're more likely to be exposed to sand, abrasive surfaces, so the eczema does take on a more inflammatory look and is more diffuse in its distribution often. In school-age eczema, we see periorbital or facial eczema very commonly, and that's because there's a lot of hand touching to face contact, and as I mentioned, in cubital and popliteal fossa, where sweat can accumulate and irritate the skin. So in adult eczema, it tends to be more in places which are prone to dryness. So the upper back and the hands we see commonly, and again, knees and extensive surfaces tend to suffer more. When we're managing eczema, the three key things we look at addressing are firstly to identify those potential irritants, because no matter how aggressively you can treat the skin, you really need to look at modifying any exposures to stop that skin barrier being irritated or worn away. We need to also implement skin hygiene plans that look at maintaining a skin barrier so that filaggrin protein defect is helped along and that skin can take on a nice uniform barrier function. And also we need to actively treat the eczema, the inflammatory process that's driving underneath in the dermis. So there's three key areas to look at. And often when I'm managing a patient, I have a plan that I think the next slide should show, where I can broadly put the patient's skin into three different zones. So a green zone where we say, great, the skin is well managed at the moment, let's just focus on strengthening that barrier. Or yellow, or that orange middle zone, where we say there's a few little things we can look at here. Let's increase our inflammatory control, let's treat with some steroid. And then a red zone, where I always want immediate contact and a medical professional or GP to look at the skin and assist with more urgent treatment. So I will now introduce Professor Sinclair, who will take us further into some newer and management issues with eczema.
So can you see me now? So my name's Professor Rod Sinclair. I'm the Professor of Dermatology at the University of Melbourne and also the founder of Sinclair Dermatology. We're involved as a lead organisation in Australia and around the world in terms of community meetings, and so I'm Secretary General of the International Society of Dermatology World Congress that will be held in Melbourne next year, and we're expecting about 5,000 dermatologists from all over the world to attend that. I've been involved in a number of publications, including the dermatology section of the Oxford Textbook of Medicine, one of the main textbooks used by medical students around the world. And I've also been involved in developing the therapeutic guidelines in dermatology in Australia. In total, I've written about 13 textbooks, multiple chapters in books, and multiple research publications. We're also involved in supervising postgraduate students, so PhD students, Masters of Medicine students, and we've graduated about 20 students here in Victoria through that program. We're also very heavily involved in clinical trials. We've conducted well over 100 trials in our centre over the past 5 years. We've currently got about 30 trials that are open for recruitment. And this is a really important aspect of the work in which we do, in that we can obtain access to some of the newest and most innovative medications, and patients can be introduced to these treatments often 5-6 years before they become generally available. And also the patients here get an opportunity to contribute to world research so that they can be a part of developing the body of knowledge that we're using to advance the science. So on the next slide, you can see this is where we work. So we're right next to the MCG in Melbourne. So if people know anything about Melbourne, they'll know where the MCG is. And we see about 10,000 patients each year. We're one of the largest dermatology research centres in the country. As I said, we are actively involved in the clinical trials, and we do treat patients with all sorts of conditions in our centre. We're also very heavily involved in education and adapting some of the latest technology, and I'll show you a bit of that a little bit later. So on the next slide, we divide our work into 3 levels. So the top level is purely devoted to research. So we have research laboratories, and that's where we run our clinical trials. We have about 25 people in full-time employment running those clinical trials. On level 2, we have general clinics. We also provide phototherapy and plastic surgery. And on the ground floor, we have a specialty hair service because that's also one of our interests. And we do hair transplantation surgery, and we look after people with all forms of hair loss. We're also involved in skin mapping for people who are at risk of skin cancer. So on the next slide, just to start the discussion about eczema. For most people, eczema is a relatively straightforward and simple problem. So when you think about the 10 or 15 or 20% of the population who get eczema at some stage in their life, you can break it down into these headings where some people are just born with sensitive skin, and you can usually pick them because they also get asthma and hay fever. And if you're born with that sensitive skin, it doesn't mean that you've got eczema. But what it means is that you're vulnerable to irritation. And so if your skin is exposed to irritants, things like long hot showers, soaps, bubble baths, ducted central heating or air conditioning, then the skin starts to dry out. And if you've got dry skin and it then gets hot, and that can occur either during the day with things like ducted central heating, or at night, if you're getting too hot under the doona, then you start to get itchy. And it's only when you start to scratch that itchy skin that you produce the dermatitis. And if you keep on scratching, then that's when it will become infected or thickened or lichenified, as we call it medically, and that's when it will often spiral out of control. So for many people with mild eczema, it's just a matter of avoiding the irritants, avoiding overheating, avoiding scratching, dealing with the infection, dealing with the skin dryness, and the eczema tends to look after itself. Now, on the next slide, you can see that we're starting to acknowledge that not everybody can be controlled with those simple measures, those simple avoidance factors. And there are some people who have what we call moderate to severe atopic dermatitis or eczema. And the basic definition of that is when it's involving more than 10% of your body surface area. And so you can sort of see on these cartoons that, if it's involving half your back, half your chest, one thigh on the front, one thigh at the back, it's very quickly that it gets up to 10%. And most of the people who I'd imagine are tuning in today would be dealing with people who have got eczema that fits into that moderate to severe category, where it's involving more than 10% of the surface area. And it's not just simply responding to those measures that we were outlining in the slide above. And so for the vast majority of people, simple measures are okay. But if you're starting to move into that group where you've got extensive eczema, it's moderate to severe, and it's not as responsive as you'd like to the conventional treatments, then that's when you've got to start looking a little bit beyond that. And so on the next slide, we can see that the researchers are now starting to understand how eczema works. So there is that barrier dysfunction that Dr. DeAmbrosis was talking about before, but there's also an immunological function. And so what you have in the body, you have circulating cytokines. And the key cytokines that seem to be involved in eczema are ones called interleukins, and in particular interleukin 4 and interleukin 13. And they circulate in your blood, and then they hit the cells in the skin, and they bind to the receptors on the surface of the cell in the skin. And when they bind to the cell surface receptors, they then activate a chain reaction, what we call the second messenger system. And that second messenger system is controlled by the JAK-STAT kinase pathway. And so when we start to try and deal with eczema from an immunological point of view, for the people with the moderate to severe eczema that's not responding to the simple measures, then we look at treatments that will target either the interleukins, treatments that will target the interleukin receptors, or treatments that will target that second messenger system, the kinase system. And so on the next slide, what we're starting to see is that these treatments are moving from the laboratory and starting to make their way into clinical trials, and hopefully soon they'll start to make their way into the clinic. So dupilumab was one of the earliest ones that came along, and a number of trials have been done that show that it's effective and that it's safe. And this one has now been approved by the TGA, the Therapeutic Goods Administration in Australia, and that's the body, which is a Commonwealth government body, that's the body in charge of evaluating all the data and saying, do you have enough data that we can license this as a safe and effective treatment in Australia? And once that process has occurred and dupilumab's got the tick from the TGA and it is licensed, then it goes for evaluation by a second Commonwealth Government department, which is the Pharmaceutical Benefit Scheme. And dupilumab is in that process now, where they're trying to work out whether the price that the manufacturer is asking for the treatment is justified in terms of the benefits it can deliver to patients. And that's a very complex process where the government guards its money very carefully. It wants to make sure that the money that it collects from everybody in terms of taxes is going to go to the area where it's going to deliver the greatest benefit. And so they have a very complex algorithm that they use to put a value on these medications, and they also work out which eczema patient should get it, because obviously you don't want to give it to the people with mild eczema who would get better with some moisturizers and heat avoidance and soap avoidance alone. You want to really reserve these treatments for the people with the most severe forms of eczema so that they get the greatest benefit. Now on the next slide, you can see that dupilumab was one of the first of many. Behind dupilumab came pralucilumab, and which was another interleukin monoclonal antibody, so another medication targeting the interleukins. And now we're moving on to medications that target the kinases, the second messenger systems. So dupilumab and pralucilumab were injections. Abrocitinib is a tablet, and this is a JAK inhibitor. And so we can go on to the next slide. And this is a manuscript that's about to be published in the Lancet in coming weeks, and you're getting a preview of some of the data. But the EASY 50 refers to how many patients got a 50% improvement in their eczema score. And what they found with these tablets was if you're using the full dose, which is the orange line, then about 76% of patients are achieving that 50% improvement in their eczema severity score. And if you're using the lower dose, it's about 57%. And if you're on placebo, it's only about 22%, because everybody knows that eczema is a fluctuating disease. The severity does fluctuate from person to person quite a lot. And so you've always got to take into account when you look at any new treatment, how much of this was just the natural fluctuation in eczema severity, how much of it's due to the medication. And then probably the more important figure on the right side is the EASY 90. How many people got a 90% improvement in their eczema? In other words, it's just about completely gone away. We found that was about 40% with the higher dose of the abrocitinib, 200 milligrams a day. With the lower dose, it was only about 18.9%, but with placebo, it was only really about 5%. So this is a significant improvement, and if you're one of that 40%, then this is a great drug. And you've got to just remember that this is just the first in a long line of medications that are starting to come through. And we saw this same process with psoriasis. The very first drugs that came out for psoriasis back in about 2006 only about 30% of patients were getting a 70% improvement. Now, fast forward to 2020, the newer drugs that are coming on the market, 90% of patients are getting a 90% improvement. So what we're seeing is that this is a major breakthrough and a departure from having to use repeated courses of steroids in these patients. On the next slide, what you can actually see, and we'll flip to the video, this is a patient who was treated with that JAK inhibitor. And what you can see is the slides at baseline, a few weeks later, a few weeks after that, and a few weeks after that. You can actually see what a profound difference it makes to their eczema. Now, this is still not a 100% improvement. It's not a 90% improvement. You can see he's still got some eczema on his forearms. This is about a 75% improvement, but in terms of quality of life and comfort, this is a huge difference. So a 50% improvement is still a really substantial impact on people's lives. A 90% improvement is bliss. You know, that's basically just relegates eczema to just a mild nuisance rather than something that you've got to deal with on a day-to-day basis. And so if we look at the next slide, one of the key things that we see with the JAK inhibitors, this new class of medications, and abrocitinib is probably one of the ones that will come to market soonest, is that there's a profound reduction in itch almost immediately. And so people are starting to see their itch reduced at day 2. So they start the treatment, and as soon as you stop the itch and you stop the scratch, you stop the damage to the skin, you stop the infection, you stop the skin thickening, and people start to feel better enormously. So even if it takes a while for the redness and the scale and the visible features of the eczema to go away, if you can actually get the itch to disappear so quickly, people know that it's working, and they start to get the results, as I said, as early as day 2, but certainly by day 15, everybody's getting a profound reduction, a -3 reduction in itch, which means that it's basically gone away. So on the next slide, the other thing that we also know that's really important is sleep disturbance. And the key thing that with eczema that disrupts sleep is the itch. And it's the itch that wakes people at night, particularly when your body temperature rises as it normally does during the wee hours of the morning. And if you're sleeping under doonas that trap the heat in, then that will aggravate the temperature rise, that will aggravate the itch, and that will then lead to the sleep disturbance. And one of the things that we showed was that there's a very strong relationship between reduction in itch and improvement in sleep. And I think everybody who's got a young child who's not sleeping well, or anybody who's not sleeping well and finding that they can't concentrate at school, they can't concentrate at work, if they can actually just get a run of good night's sleep, they're going to feel so much better. And that's what we're seeing as one of the almost immediate benefits when they start on these treatments. And so on the next slide, we're also starting to get some information as to how one treatment compares against another. And so we're starting to get some comparative trials running, comparing the JAK inhibitor to the interleukin injection, the anti-interleukin injection, and we're starting to get an idea as to which treatments are more likely to work, which treatments are more effective, understanding the differences in the treatment, and that will actually help us select which patients we should go down, which pathway A, pathway B, what's going to be the ideal treatment. And we're still learning about this because it's not really until we start to use these treatments in the real world, then we start to build up experience of thousands of patients that will really fully understand how to get the best out of these agents and what combinations of treatments might work best. And on the next slide, what we can actually see in this comparative data is that the JAK inhibitors seem to be slightly better than the injections. They seem to work slightly quicker, so that you're starting to see a good response at 2 weeks, whereas the injections take a little bit longer. But at the end of the day, both of them are relatively similar, so there's not a huge difference between one or the other. And so you will get some patients who prefer to just have an injection once every 2 weeks, whereas other people who prefer a tablet once a day. So we'll just have to wait and see what patient preference how that drives that, and what one's going to work best for which people. But there's also going to be differences in time points. So I think that the dupilumab will be available to patients sooner than the abrocitinib because it's a little bit more advanced in its development. So we started the trials with dupilumab probably 6 years ago. So we've been treating patients with that agent for 6 years in our clinic. The abrocitinib, we probably only started using that about 3.5, 4 years ago. So we're very fortunate in Melbourne that we've got probably about 200 patients in our clinic who have now been the beneficiaries of these medications. and they're often the patients with the worst eczema, the ones who we are having repeat courses of steroids, repeat admissions to hospitals. We've been able to get them all off their prednisolone, no more admissions to hospital, and we've been managing them with these new medications, and it's been a real game changer for the people who've had an opportunity to enroll in these trials. And so on the next slide, we can also get some information that the innovation is not just happening at the severe end of the spectrum. It's not just people with really severe eczema for whom the new innovation, the new science is coming along. We're starting to see these JAK inhibitors being developed as creams. And the first JAK inhibitor cream is one called delgocitinib, and that one is already showing a lot of success in the clinical trials, and that's being used for people with mild eczema, people with less than 10% body surface area, or people who don't want to go on a systemic medication, they don't want to take a tablet, they don't want to have an injection. They're starting to develop these agents as creams, and of course these creams are not steroids, they don't have any of the side effects for steroids, and so for the people who've been using steroids for a long time and starting to become intolerant of them, then it's really nice to know that there's some innovation at the mild end of the spectrum as well as just at the most severe end. And so on the next slide, I'll just finish up there and open it up to some questions, but I think there's probably never been a more exciting time for people with eczema in terms of the innovation that's going on. We've been along this path with psoriasis, and we've just seen how transformational it's been for our patients with psoriasis. And unfortunately, eczema has been 20 years behind. And so we've had access to these treatments for our psoriasis patients for the last 20 years. We're just starting to get them access to for our patients with eczema, and we're starting to see each dermatological disease one by one just being picked off by a better understanding of the molecular biology, the molecular mechanisms that drive that disease, and we're starting to develop targeted therapies that will specifically deal with each one of those diseases. And we're seeing that innovation at cream level, we're seeing that innovation at a tablet level, and we still have the fundamentals, so there's still the basic practices of soap avoidance, basic practices of avoiding overheating, moisturizing the skin, using steroids for people with mild disease, but for the people whose disease isn't well controlled, then there's now new possibilities. So I'll finish there. Thank you very much for your attention, and thank you to the EAA for organising the webinar today.
Thank you very much, Dr. Kate DeAmbrosis and Dr. Rodney Sinclair for those Professor Rodney Sinclair for those wonderful insights into new treatments and an overview of eczema in general. A lot of people still get very confused about the cause of eczema, and they often hope there's a cure. And even though we know there's not a cure, it's great with these new treatments lending to much better outcomes. Thank you again for explaining them so well. We're now going to open up the session for questions and answers. Okay, so the first question we have is someone's asked about their son who's got bad eczema, and it's much worse at night, which we know is because of scratching and because of getting overheated. So they've asked us specifically about bedding. So they want us to recommend some linen or some bedding. So pretty much across the board, don't use doonas. A couple of cotton blankets is a good idea that you can layer on or off. And when it comes to sheets, usually cotton or bamboo is a good choice. There's also a specific range of cooling sheets which help keep you much cooler called derma sheets, which are available from a company called allergen.com.au. But also to look at your bedroom in general, make sure it's well ventilated, you don't have the heating on too high, or try not to have heating if possible. Some people in the winter, eczema sufferers, even need to sleep under a fan. So you've got to look at all these factors. Dust mite protective covers are important as well. So we want to limit, contact with allergens and make sure that the sufferer is quite cool. So what are the best ways to manage eczema and hand hygiene during this pandemic was another question asked by a few people. The EAA website eczema.org.au and our EANZ website as well have information on COVID-19 important hand washing information. It's also available for download on the handouts section of the webinar. So read through that information. We've worked with the College of Dermatologists to get the best sort of outcomes. You know, it's very important to keep your hands clean, but to make sure you're not drying out your skin too much. So what types of makeup can I use on myself or my child with eczema on their face that won't trigger a flare-up? This can be really difficult and tricky because everyone's skin's different, so what works on one person won't on another. But a lot of evidence we've collected from members and other people has shown that mineral makeup is generally less irritating for people with eczema. But generally, a good rule of thumb is to try to use makeup designed specifically for sensitive skin, and always patch test it first to make sure you're not going to have a major reaction. Our next question is, are there different types of eczema and how do I find out what type I've got? There are different types of eczema, and it's really important to consult a specialist dermatologist who's expert at diagnosing skin conditions. Most people go to their pharmacist or GP, but they don't have enough experience. So it's really important to consult a specialist, as you do with any disease. Okay, so our next question is, so are there different treatments based on the type of eczema I've got? So again, your specialist will be able to discuss all treatment options which are best suited for your skin condition. It's exciting, there's new treatments coming out, but for a lot of eczema sufferers who only have it what we class as mild to moderate, avoidance of triggers, using a topical steroid when necessary, and using the type of products that won't irritate your skin are really important, and you can get really good management. So what other options are there apart from steroid-based creams? There are a lot of other options available, which Professor Sinclair's covered, you know, the latest and greatest. But even if you have quite severe eczema, there are other treatments available. There's immunosuppressant treatments, there's light therapy treatment, and of course the biological therapies, which are what Professor Sinclair covered. So again, consult your specialist dermatologist and get some information about what can work for you. We know there's a lot more things available these days, so it's great to find out all your options. So we got a question about topical steroid withdrawal. There's been a lot of stuff in the news about it. We get asked about it quite often. So how serious is it, and what steps can I take to avoid this from happening to me? Topical corticosteroid withdrawal is a rare adverse reaction relating to the use of a topical steroid after it has been discontinued. This reaction can occur after prolonged, inappropriate and/or frequent use or abuse of moderate to high potency topical corticosteroids. So again, talk to your specialist about correctly using your topical steroid creams. Quite often eczema sufferers have a different range of creams in different strengths. So it's very important to use the correct one for the correct part of your skin. So the next one is there any reason that my child seems to react better on a particular type of steroid cream regardless of strength? So I'm going to ask either Kate or Rod to answer this question, okay?
Okay, I'll step in. So generally speaking, yes, we do see that some steroids can work better with particular skin types. That can come down to a lot of different factors. Sometimes the vehicles, so the ingredients other than the steroid that the active is sitting in, can work better on a more hydrated or a drier skin type. So some people respond better in that regard. Some of the vehicles can sting, and that can lead to avoidance of the treatment. which means that you're not the response may not be reflective of how much steroid is being used. So there can be a number of different factors as to why one cream or ointment seems to be working better on a skin type. Generally speaking, we prefer to use ointments as they penetrate the skin better and allow the active delivery of the ingredient to where it needs to go better. But in saying that, there's always a site and a different temperature can vary that as well, where we go for creams or gels or even lotions in some areas. So it's not a one treatment fits all, and it does have to be adjusted to both the location of the eczema and the environment that the patient is living in. I hope that helps with that question.
That's great. Thank you very much. So my next question we've been asked for one of our specialists to answer is, if my child's facial eczema seems to be triggered by eating particular foods, is that considered allergy or just hypersensitive skin reaction?
There's a couple of reasons why that might happen. So one is it might just be the acidity of the food. So if you've got sensitive skin, then you might be very sensitive to acid food. Similarly, if you put curry on your skin, it's going to irritate even normal skin, even if you don't have eczema. So sometimes it's just the irritancy of the food. Occasionally, it can be a food allergy. Now, if it is a food allergy, what generally happens is that you get an immediate tingling or burning sensation on the lips, and you get a flush that occurs within about 5 to 30 minutes. So it occurs pretty soon after the ingestion of the food. And that then may follow over the next day or two with a flare-up of the eczema. But it's usually in that sequence. And so if you're not getting that sequence of events, it's much less likely that there's a food allergy that's aggravating the eczema.
Okay, our next question. Thank you very much for that answer. Our next question is, how long can we use the steroid cream if the eczema is not 100% cleared, but average, despite applying steroid cream for more than a week, trying very best on applying moisturiser as well 2 to 3 times a day? So one of our specialists, please put your hand up.
Yeah, I can take this one. I think, again, it's not a one answer is going to fit all, and it depends on where this eczema is happening, how long it's been going. But what I do with my patients is you don't stop treatment until the eczema is cleared, and even 48 hours beyond that. So often the skin can look good. It can return to quite a normal looking skin, but there's still some inflammatory process bubbling on in the lower layers. So I like my patients to treat 1 or 2 days beyond the skin looking normal. So that's very important to turn off that inflammatory process. Then it's a matter of tapering down or stopping the steroid, but really increasing the maintenance in that barrier to make sure it doesn't recur or there's not another flare up. So I think if the skin hasn't cleared, then probably not enough steroid or not enough strength of steroid has been used. It's great that you're using the moisturizer in conjunction, and that is really important. But I think the strength of the steroid and duration needs to be looked at.
So the analogy I often use with my patients is eczema is a little bit like a smouldering fire. And if you turn your back on it too soon, it's just going to reignite. You're going to be back to square one.
Great one.
And what you've really got to do with eczema is put the fire out. And so there's lots of different ways of doing this, but what I often say to patients is use the cream once a day, every day until it's completely gone, until you've got some cream on your finger and you can't actually see where to put it. And then once it's gone, continue doing that for about another 2 to 3 days. And then after that, maybe do it every second day for a couple of weeks, and then maybe even once a week for about 5 or 6 weeks. And that will really put the fire out. So if you're finding that you're riding this roller coaster where you treat it, it goes away, you stop the treatment, it comes back again, you treat it, it goes away. If you want to get off that roller coaster, then you've just got to go a little bit longer than what you'd thought. And there's certainly no safety risk of using your steroids for more than 1 week or 2 weeks. You can use them for much longer than that. And in the long run, you'll end up using less steroid cream if you put the fire out, rather than if you have to keep coming back to it because you can't get off the roller coaster.
That is wonderful advice from both of you, and it is the #1 question we get asked, and that's why we say to people it's really great to consult a dermatologist, a specialist, who will give you better advice than maybe your pharmacist. Pharmacists are wonderful, but they don't know everything about, for example, using topical steroid. So our next question for our specialists is, I'm a mum whose hands are always in water because I'm cleaning up after kids or doing dishes or laundry. What advice can you give for many parents in this situation where we can protect our skin besides just wearing gloves?
So I suppose hand washing is a really interesting thing. So if your skin is normal and you've got to do lots of hand washing, then protecting your skin with lots of moisturizers will often nip the problem in the bud and stop you developing dermatitis in the first place. If you've already got, if your skin's normal, one of the things that you can actually do as an alternative to washing is use the sanitizers. And the sanitizers will be a little bit gentler on normal skin than the soap and water. But in any case, whether using sanitizer, soap and water, moisturizing afterwards will protect your skin and stop the problem happening in the first place. If you've already got a hand dermatitis, you often find that the sanitizers sting and irritate, so they become a little bit harder to use. And so if you can't use your sanitizers, then you're obliged to use the soap and water. And in that situation, using a small amount of soap is important, making sure that you rinse the soap off carefully, and making sure that you dry the hands carefully, and then applying moisturizers are all going to be good. And then, of course, if you've got any active areas of dermatitis, just treat them with your cortisone cream and treat it until the dermatitis goes away, and don't stop it too soon. That's what we were talking about before.
Yeah, that's great advice. And as a hand eczema sufferer myself, one thing I find helpful is I have a pot of like a moisturizing lotion near every sink in my house, and it's quick and easy to apply when I've washed my hands, and it does avoid that drying out process happening as easily. Our next question is, are there any products available without steroids that are suitable for babies with eczema? So this is someone who doesn't want to use steroids. Also, my baby's skin has rough patches. Once the skin settles, is that normal? So I'll ask one of our specialists about this.
Yeah, I can. So I think just assuming that diagnosis is eczema, and it sounds like it is in this patient, I think the one thing I can reassure you is that steroids aren't harmful for babies. It's actually probably more troublesome in a way to leave eczema, particularly in babies untreated, because it really leaves that skin barrier exposed, and then you're putting the child at risk of bacterial infection and viral infection. So it's really important to treat eczema effectively, and that often does require steroid use. And as we've been saying, getting in and out with an appropriate strength is important, and it often minimizes the time. So rather than putting a very low dose steroid on for a long period of time and not getting anywhere, it's much more effective to use a stronger steroid for a short period of time, switch the inflammatory drive off, make sure the skin is completely normalized, and then go back to a reliance on a moisturizer, good quality moisturizer. I think perhaps that reference to skin rough patches that are still present once the skin settles, and that's what I'm talking about. Often you can feel the eczema despite the skin looking quite normal, and that means that there's still some grumbling on there that you could prolong the steroid treatment for until that rough patch goes away, and then rely back on the moisturizer. So I think in answer to your question, perhaps a bit more steroid for a bit longer might sort that problem out, and then relying back onto the moisturizers to maintain that skin barrier.
And there is another aspect to this about treatment of babies, and that's the thing that we call the atopic march. And the atopic march is that babies often develop eczema in the first few months of their life. By the end of the first year, they start to develop food allergies. By about 2 or 3, they start to develop asthma, and then they go on and develop hay fever when they're about 5 or 6. And there's some emerging data in the literature to suggest that if you undertreat the eczema in the baby and don't control it well, you're going to increase their risk of developing the food allergy and the asthma and the hay fever later in life. So there really is an imperative to manage the eczema and get control of it. Now, there are lots of ways you can do it. There are some steroid alternatives like Elidel cream, which is non-steroidal, but far and away the most effective are steroids. And often using a steroid briefly, getting the eczema better, and then following it up with moisturizers and other treatments down the line will often be the safest thing to do for the baby. So you've got to balance that out. And if you do have a philosophical objection to steroid creams, then you probably do need specialist advice so that you can really work out how to get the best out of all the other treatments. Even tar creams have been used in the past, and ecthamol creams. So if you're really going to take the most effective of the treatments out of the mix by not wishing to use the steroids, then you really will need specialist care to try and get adequate control of the eczema, to try and reduce the risk of this atopic march happening in your baby.
And that's a very interesting point we deal with. We must get this question at least a couple of times a week. It's steroid phobia, and people get very confused about how much is appropriate. We find that if they visit a specialist, a dermatologist, they get good information, but patients that rely on GPs and pharmacists often get quite misleading information, and then they go home and their mother-in-law or whatever says, you know, this is dangerous. So it's really good to know that, you know, if you go and see a specialist, they will explain in a lot more detail how topical steroids work and why they are so important.
And we have options. And I was going to say, and we have options, so that if you yes. really do have a very strong philosophical injection, then the dermatologist can work with you
to
get the best control of the eczema. And so always keep that in mind, that there are many different ways that we can treat eczema. We've got lots of tools at our disposal. There's even emerging creams coming along. There's new trials with crisaborole. There's other treatments emerging, but you've got to at the end of the day, the best thing you can do is control the eczema. How you do it is open for discussion.
Great. Well, our next question is, my child has eczema around his butt and anal area. Is there a reason why it's there specifically? So either Rod or Kate.
I'm happy to. I think this is a really common site for eczema, particularly in a younger child that's still in nappies. This area, as you can imagine, is very prone to bacteria, and feces and urine are quite irritating. So the first thing to do in this location is to make sure that ideally there's baths involved, making sure the areas are kept very clean and washed well, and then a regular barrier cream to try and give some barrier between any irritants for a child in nappies before it can erode the skin. If it's gone beyond that and there's more of a eczema component, then that does need treatment as we would in other areas. So we need to employ some topical corticosteroid. Often there can be a complicating infective process because of the bacteria. So often swabbing to identify if there's any particular bacteria causing an issue, and that might require a course of topical or oral antibacterial therapy. So depending on how severe, how far that eczema has spread, then it's probably best to be assessed by your general practitioner or your dermatologist and have a treatment program prescribed.
Great advice. Now, the next question is for Professor Sinclair. Can the experimental trials impact my fiance who suffers from chronic eczema with her ability to have children?
So it's generally an exclusion criteria to participate in the trial that we don't, the manufacturers don't want people who want to have a family enrolled in the clinical trials because it's going to take some time for everyone to feel comfortable in the safety of it. However, if you have these treatments and then you stop the treatments and then you start your family, then there's no problem with that. So it's not going to affect their future fertility, their future ability to have children. But it's one of the conditions of entering into the clinical trials that you don't fall pregnant whilst in the trial.
Okay, great advice. I think that sort of brings us to the end of our session. We can probably do a couple more questions. Are you guys happy to answer a couple more? Okay, so would you recommend a humidifier if you're allergic to dust mites?
So I suppose I would recommend a humidifier irrespective of whether you're allergic to dust mites or not. So I think everybody with eczema is prone to dry skin and they would benefit from some increased humidity in the air. Now, sometimes that's just a matter of choosing the heater in your house. So if you've got a ducted air conditioner or ducted heater, that will often reduce the humidity in the air, and you may need to compensate that with a humidifier. Now, what you want is normal humidity. So it depends on where in Australia you're living. So if you're living in Cairns, you're unlikely to need a humidifier. If you're living in Tasmania, you're probably more likely to need a humidifier. And so you can actually measure the humidity in the air, and you can work out whether it's above or below. And from a heating point of view, hydronic heating seems to be a better way of heating the house without reducing the humidity in the air. Now, dust mite allergy is a really controversial topic. I remember doing a lot of work on dust mite allergy and patch testing people to dust mite probably 30 years ago when I was working in England. And one of the things we found was that it was much more important for asthma than it is for eczema. But there nevertheless will be some people for whom it is relevant and important, but it's it doesn't seem to be as critical an issue for the people with eczema. And you're going to get much more value from avoiding soap and using moisturizer than you will from really heavily pursuing the dust mite. There are outliers for that. There's always differences from person to person, but on a population basis, that's where the real value is.
Okay, great, thank you. So our next question, is there a connection between diet and eczema? So open for whoever.
So
I think Prof. Sinclair covered that briefly, but there is a very small proportion of patients that have diet that does trigger eczema. Generally, that presents in the first 6 months of life, so it is quite a specific form. And generally, as Professor Sinclair said, it's a very temporal thing. So we see within 30 minutes of exposure to the food, the eczema is flaring. So unless there's that clear temporal and usually very early onset, then no, diet does not tend to trigger eczema, I think is the easy answer.
And so,
thank you.
From a really practical point of view, if you've got a food allergy, it's usually going to be pretty obvious. Every time you eat that food, it flares it up within minutes. And so if you've found a food that clearly aggravates the eczema, then the prudent thing to do is avoid it. But if you can't identify a food very easily, then it's quite likely that even with specific food testing, allergy testing, you're unlikely to develop a food allergy that can be removed and lead to improvement of the eczema. So lots of people with eczema will be allergy tested and they'll find that they've got an allergy, but it's not a practical thing that they can suddenly remove that food and their eczema goes away. And so it doesn't really, it's not a game changer. And so from the practice, so I would rarely refer patients off for allergy testing, but many of my patients do go for allergy testing, and I've watched them over the years and kept a little bit of a record of how many patients have come back and said that was money really well spent. I got great value out of that allergy testing, and it's really made a difference to my eczema. And over the last 25 years, that number is still 0. So I don't know whether you've had better luck, Kate.
I think exactly right. I would very rarely find that anyone has any benefit in treatment from exploring that allergy path.
And yet it is the #1 question we get asked almost on a daily, well, it'd be behind steroid use, topical steroid use, but we get asked about allergy testing.
It's wonderful to put a cause on it, I think, and that's one of the things I do struggle with parents particularly. It'd be so lovely for me to be able to say, look, if you don't eat strawberries, the eczema's cured, but unfortunately it's just not that simple.
Absolutely, so great. So we have another question. What are the short-term and long-term side effects of topical steroids? And can you please tell me about topical steroid withdrawal, which we did sort of touch on before, but maybe a little bit more explanation would be helpful.
So I suppose the easiest way to think about this is that the benefit of a topical steroid and the side effects of a topical steroid are going to be related to dose. Now, one of the problems that all of our patients suffer with dermatologists is that dermatology is the only profession that prescribes dosages in adjectives rather than numbers. Every other branch of medicine tells you you take 5 milligrams of this tablet, 50 milligrams of that tablet, and dermatologists often prescribe the topical cortisone creams with adjectives like use liberally, use sparingly, and it's really hard to know what that means. And so if you use lots of the topical steroids, use a high dose, you're going to get a more profound improvement in your eczema than if you use a low dose. And you'll also get more side effects because you can't separate the benefit and the side effects from any medication. You know, they're pretty much all linked in. So to specifically answer the question though, the short-term side effects are very limited. So topical steroids, even the really strong topical steroids, are going to be very safe for use for 1 week, 2 weeks, 3 weeks, 4 weeks. Beyond that, then there's going to be some site differences. So the face is very sensitive to strong steroids and you shouldn't use them on the face for more than a couple of weeks. The armpits and the groins are also very sensitive to strong steroids and you shouldn't use them for more than 6 to 8 weeks. Elsewhere on the body, it's going to be dependent on how inflamed the skin is and how thick the skin is. But the long-term side effects can be skin thinning, they can be redness and broken capillaries, and in some cases you can even get stretch marks. The steroids, a small amount can be absorbed into the bloodstream, but it's very uncommon that there's enough absorbed into the bloodstream to cause a problem. And that is one thing that we can manage because there are some steroids that aren't absorbed into the bloodstream or they're activated as soon as they get into the bloodstream. And there are others that will have a generalized effect. So the answer to the question is that it's related to dose, and the dermatologists, I think, are much better at demystifying the adjectives around steroid prescribing and give you a much better idea of exactly how much they want you to use. And so if you've got uncertainty about it, you've got uncertainty about the safety of it, then you really want to pin down your doctor and say, how much should I use? And many dermatologists will actually give you a demonstration in the clinic and show you exactly how much to use.
Okay, that sounds really good and good advice. It's just one of those things that people tend to question over and over again, and it doesn't matter how much reassurance you get them. There's so much talk about using topical steroids in the general population, and there's just so much misconception about it. So it's really unfortunate, and it's something we try and address all the time, and I should imagine that you two do as well. I think now we're really going to have to wrap it up. So I'd just like to say a huge thank you to our specialists, Dr. Kate DeAmbrosis and Professor Rodney Sinclair. It's been really, really wonderful and given us some great insights, especially with your answers to our questions. As we said before, if you've got any more questions, please send them to help@eczema.org.au and we'll endeavour to get them answered. Yes?
Yep.
Sorry,
And I was just going to add one thing that, if there are patients with severe eczema who are struggling, who would like to participate in a trial and they live in Melbourne, then look us up on our website and you can look at ways to volunteer in the clinical trials. Similarly, people with mild eczema, we've also got creams that can be used for clinical trials. And the final thing that we're doing, and this comes back to persuading the government to fund the dupilumab for patients with eczema, is the government needs to know how badly eczema affects your life, so that they can almost put a dollar value on the impact that eczema is having on your life. And so if there are patients in Melbourne who would like to participate in a trial, we're doing a survey where patients come in, we ask them what impact eczema is having on their life, how it's affecting their sleeping, how it's affecting their function at school and work. And we're matching that together with the severity of their eczema. So we're scoring their eczema, but there's no intervention in that. And in fact, participants get paid $100 for participating. So if there are people in Melbourne who'd like to participate in that trial, we'd love you to contact us at Sinclair Dermatology, and that will really help us develop the new treatments, but also help government understand just how much eczema affects people and how much value government should put on making eczema better, because they're going to need to spend some money to make available these new innovation treatments, because it costs, I think it's $2 billion to bring a new drug to market, so it's not cheap. And so government's going to have to pay for it if it wants to make these treatments available to our patients, and we need to help government understand how much they need to pay for it because of how profound an impact eczema has on your life.
Yeah, that's great. And look, if we can share those links on our Facebook page, and if you need that information, give us a call or send us an email. As mentioned earlier, we will have a 5-minute post-webinar survey. We would appreciate it if you could fill it out to help us understand how you found our session to be, and to help us get an idea of what you would like to learn for future webinars. Also, if you complete the survey, you will be sent a virtual goodie bag that is amazing. Our wonderful corporate partners have donated to it, supplying a range of discounts and goodies to help you manage your eczema over this very dry season. There will also be random draw raffle prizes announced, thanks again to our amazing corporate partners. So we will be in touch with you in early June if you have been announced as one of the lucky winners. The video recording and handouts will also be distributed to the emails you signed up with for you to refer to in the future and share with your friends, family or colleagues. Thanks so much again for your participation and enjoy the rest of your day.
Thanks, Cheryl.